Okay, welcome. We are so excited to be here today with these two powerhouse women, Dr. Natalie Crawford and Dr. Janelle Luke. Our audience has been asking us to cover this important topic, and we are finally here to discuss what is infertility and how do I know if I'm infertile? So, Dr. Crawford is joining us from Austin, Texas, where she is a trailblazer in the fertility industry. We are thrilled to have you here with us. So, thank you so much for taking the time. And Dr. Janelle Luke is joining us from New York City and is the medical director and co founder here at Generation Next Fertility. I know personally that her mission is to educate and empower women everywhere and is at the forefront of everything she does. So, without further yourself to the audience.
Hi. I was early here today giving the opening as the medical director of this conference. I hope everyone had a great time. I'm between patients. I want to check in on Destiny and check in on you guys. It seems like everyone is sharing their stories, sharing their history, sharing their experiences, and this is what this is all about: is to empower, educate for fertility patients or patients who are struggling with miscarriages and many other you know infertility diseases that can that they don't feel alone, that they feel there's a community, that they feel empowered, that they can ask the doctors the right questions or the questions that they feel like, oh, I can take a deep breath tonight because I got it answer. So we are here for that. And I hope that this is helpful for this session. Without further ado, it is exciting for me to talk to Dr. Natalie Crawford. I don't know, some of you know, I'm not good with Instagram, not good, good with many of this social media. And in so many ways, a couple years ago, I went on. Someone introduced me something called Facebook. I know you're like you're so ancient, Dr. Luca. Yep, I am. And I went like, what the heck? You can talk like this on Instagram, educate, and people are loving it. And in so many ways, that's always been my mission. Some of you know, I the reason I kind of founded Generation X is not to generate cycles. I'm not as great as a businesswoman, but more want to talk and connect with the audience and connect with patients and really share also my story because I was also a patient. I was also inflicted with endometriosis, and no one talked to me about this disease.
Mhm.
I day in day out. Some of you who are like professional women like me or not, or a housewife, wherever it is, busy day and suck it up. That's what my OBGYN told me. And
Mm.
when I was first diagnosed in my residency with a dermoid cyst, they went in and they say, hey, Janelle, you have endometriosis. And I didn't know in medical school, didn't know in residency. Yes, I am a little bit competitive, went to all this Ivy League places, but I was chasing for my dream, right? And I didn't really take care of my body. And when they told me that, and then they said, and at that point I wasn't married, didn't meet my husband, and they said, Janelle, you better get married now and have a baby. And that is kind of insensitive too. Also, I mean,
Yes.
I'm working 80 hours per week, and anyway, so finally, luckily, I did meet my future husband and during medical school, and ultimately we did have children, but that was important knowledge because I did have trouble having my second child. It was after in my 30s, and because as you guys know, and Natalie may also share that in her Instagram, is a long road. 4 years of medical school, 4 years of residency, 3 years of fellowship, and if you start even 18, you're at 30 by the time
You're
you find your
old.
first job. So any case, and then yes, my career then go on and really joined a couple of practices, but I didn't it was not my calling. It was more like, Janelle, go and got more cycles in. I'm like, okay. But that was not it. I don't feel that was it. And then I saw Dr. Natalie Crawford's amazing Instagram, and she really taught me a lot. I don't know how she answered my teams and texts, and she has many followers, 100,000 followers, but somehow I asked her a question. She's like, you go, girl. Keep on doing what you're doing. I was like, okay, it's 11 p.m., but thank you. And that's why she's so successful. And she's a trailblazer, amazing on CNN, appear on CNN, many big social media. And it is my honor, privilege to have her here with us today, answer some fertility questions. So, Dr. Crawford, please introduce yourself and we can start with the
Dr. Luke,
conference.
thank you so much. I love everything you're doing. And really, we share such a common mission about making this journey more relatable and helping people with education become better advocates for themselves, even if we can't take care of them ourselves. And I have a very parallel journey where in my own training, I had infertility and recurrent pregnancy loss. And despite being an expert in the field, I found that a lot of the questions I actually had, nobody had answers to. And I found myself, because we're old, on online forums and like searching for information to try to figure it out. And this was before the days of social media. And I just love the journey of breaking the stigma of infertility. People are
Mhm.
really sharing their stories and being so vulnerable, and it's so inspiring to other people. But that's really what I've always thought is, gosh, I wish I could have had this information sooner. And how can we reach more people than we can really see in a day? Because you can only sit across from the desk from so many people. And professionally, similarly, joined some practices. And, a lot of corporate IVF is very, very corporate. And so 4 years ago, with a partner, we opened a physician-owned practice here in Austin called For Fertility with the same ideals, right? That this should be very personalized and that it's not about selling IVF, but it's about supporting people through the journey and helping them make the decisions that are right for them. So I'm so honored to be here today, and I love that you're doing this.
Thank you so much, Dr. Crawford. And this is exactly my opening have said. We're trying to make IVF cycles or even this journey less transactional, but more transformational, that we hopefully can transform their lives, be with them with one of the most hardest time. I just finished a consult, it is not easy. Patient having recurrent miscarriages, they have a healthy body, but they start to question. They're like, doctor, what about my immune system? What about, I'm like, yes and no, but don't distrust your body. You can be a mom. You do have the good uterus. Like they do so many exams and thousands of tests. So, well, this leads to our first question, very
Yes.
conveniently. Um, I so um, Question number one. Um, what is the most common sign of infertility, and what are the most common causes of infertility? Dr. Crawford, you want to take a hit on that?
Yeah, for sure. So the official diagnosis, if we're talking about, what is infertility, is going to be the inability to get pregnant if you're trying for 12 months, if you're under age 35, 6 months if you're over age 35. That being said, what are some red flags and warning signs? Because I think one thing, Dr. Luke, that we both see is that these numbers are somewhat arbitrary, right? They're based on a population, and what are the odds that spending the money to do the testing will find something wrong? And so if you have warning signs that something is already wrong, such as severely painful periods, irregular cycles, difficulty having intercourse, then there is no need to be forced to wait this amount of time. In a similar fashion, I think it's really important that we start talking about age-related infertility as one of the top causes. And even though that doesn't always fit on that general things that we test, like your fallopian tubes and your ovulation and your sperm, as we get older, our eggs become less chromosomally normal. And so stepping back and looking at the big picture about how many kids do you want and the timeline that you have, and does that make sense, sometimes warrants an earlier evaluation and potentially more aggressive treatment to fulfill all of your goals. So I think sometimes this idea that you have to wait 12 months. I will see patients who have 3 periods a year who just have been waiting to meet this magic 12-month number. And that one is so hard for me. And I'm sure it's hard for you too, because we obviously know something is wrong and need intervention a lot sooner.
Thank you. I think one of the most common cause, and I agree with Dr. Crawford, is really they keep on asking me, Dr. Luke, how's my eggs? I said, there's no blood work for egg quality. there are only two numbers that usually really define equality. One, before you walk in the door, I know is your age. Two is how long you have tried, the number of years you have tried. So if, of course, with the intake of the tube and sperm, because majority of the time people have the required four things to get pregnant: uterus, egg, sperm, tubes. But they still cannot get pregnant. And that is when I know there's something more to it. But then that is maybe possibly equality. But the most, I think, frustrating things for these patients is that equality has no really a designated molecular level that we can measure. And one of the things I want to really share, and I kind of thought of this as an Instagram show about it, is that it is asymptomatic when the egg deteriorates. Means the patient cannot feel the eggs that is declining. So lots of our patients who came to us who are young and looking at the AMH is like, what? My AMH is 0.6? Now, be mindful, and Dr. Crawford, I love your Instagram post one time. AMH does not define your fertility potential, and ABOC wrote that, which is they published that AMH is not for that. However, it does educate, inform, empower that your egg quantity can be less. And as a result, you may want to be more empowered and ask all the questions that you need in your 20s and early 30s, knowing that is happening. And I've seen empowerment education about those AMH levels also important. But at the same time, it is vulnerable because you still don't know your egg quality. And the only thing we know is that in your 20s, your egg quality is supposed to be better, have a higher percentage of better quality of eggs. But it starts to decline even at the age of 25 onward. So it is also kind of unknown and known kind of entity, and which makes infertility part of a very frustrating process. So thank you, Dr. Crawford. Destiny, do we have a second question?
Absolutely. So, what about birth control? Can birth control make you infertile? I hear this a lot from my girlfriends. Like, should I stop taking it? Ask Dr. Luke. So what do you recommend?
Birth control does not make you infertile. I think that's a really important thing to talk about. But birth control does need to be stopped at a certain time before you want to get pregnant, and it can also interfere with test of ovarian reserve. So as we're talking about AMH testing, and that is a method of quantifying the number of eggs, as Dr. Luke said, it's not telling us about the quality of those eggs. Because some hormonal contraceptive options prevent you from ovulating for a significant amount of time, the cells that make AMH might also be suppressed. This doesn't mean that the birth control is actually causing you to have less eggs or causing infertility, but it is making it harder to interpret those tests. So if you do a random AMH level and you're on the continuous birth control pill and it comes back low, certainly one thing to think about is, should you stop that for a couple months and repeat it? And usually we do that concurrently with evaluating other things. But the thing that's hard about birth control in today's age is so many of us were started on it so young for an actual medical problem that wasn't well defined. So, oh, I had painful periods, or oh, I had irregular cycles. And even if birth control potentially was an appropriate treatment option for it, without getting to that diagnosis or even being told, hey, something may be wrong, you're 18, so maybe it's not worth investigating. But, before you want kids, we should definitely come off of this and try to get to the bottom of it. Because people will be stopping their birth control and then very frustrated that suddenly their cycles are irregular, and they might think, oh, did the birth control pill cause this? The reality, the birth control pill was just masking it. So while you were on the pill, you didn't have that insight that something was off. And the other thing is that if you do have like a hormonal IUD and you don't have periods, sometimes the lining can become so thin that in a way that does cause some short-term infertility. It will recover as long as you're ovulating. But I recommend, and I'd love to hear what Dr. Luke says, but I recommend hormonal IUDs be removed about 6 months before you want to get pregnant. I recommend that you stop the birth control pill somewhere between 3 to 6 months, pending if you've used it continuously, like every single day. I like more 6 months, but just regular pill usage closer to 3. And I think one thing people do not know, and luckily it's not quite as common, is that the Depo-Provera shot can prevent ovulation for up to 18 months. So even though it's only proven to prevent ovulation for contraceptive purposes for 3 months, one single shot can prevent ovulation for up to 18. So if you think you want to be pregnant, potentially start trying in the next 2 years, then that should not be the option that you're leaning on for contraception.
Okay, that's very insightful. Dr. Luke, what are your thoughts?
I love the idea. Well, I love the idea of the awareness that people have to be, what Dr. Natalie Crawford was mentioning, which is that people on the pill mask their symptoms
Yeah.
because now they don't know what happened in the past. And lots of patients always come to me, I don't know why I was on the pill. I had irregular cycles, so I was on the pill. Okay. What did the doctor explain? I don't know what's menstrual cycle. I just have irregular. I just different from my friends. And so usually they're either the 17, 18 age, even they would think just seeing pediatricians, they would just put them on the pill. Same thing with
Hmm.
endometriosis. If you do
Yeah.
have the underlying disease, you don't know because now you're on the pill for all this time. Now you stop the pill and you're trying to have sex to get pregnant or trying to get pregnant, then it becomes a very vulnerable time because then you forgot that was happening. Pain may come back or may not come back, but it's important to be aware that you still have pain, or they would say, oh, it's just the pain with the period. And so it's very fascinating. Sometimes getting pain during period in my first fertility consultation is not easy because people do not really, they think it's normal. It's like,
Normal.
hey, yeah, I'm
Yeah.
wearing my shoes to go to work. And like they're not going to mention something really weird to that,
Right.
so that, however, is the problem because it will be one. And sometimes for me, taking history, I'll always have to remember: do you have pain with your period? And then some of them may say one day of cramping. Okay, whew, I did miss something. But then after some time, we're like, hey, it's like, yes, Dr. Luke, I didn't mention this, but I have excruciating pain. Get off work, for
Yeah.
5 days straight. So I think the pill I so birth control is reversible, is totally a reversible contraceptive for the audience to understand. But it can mask certain symptoms, and that becomes very confusing when you are having issues getting pregnant because you are masking it. Doesn't mean they disappear. It was still in your body, but because you were taking birth control pills, it suppresses it. So understanding the disease, understanding your menstrual cycle, that can really help. Finally is I don't know, Dr. Crawford, I see patients very interestingly is they're avid athletes. To the audience, no problem working out, please keep on working out, but they were like in the college years or they were joining athletes, so they were on the pill since they were younger, in 15, 16, just controlling birth control pill. Then they will get off the pill at 29, 30. They ran to me after they stopped the pill because now they got married, they find their partner, they want to get pregnant. They didn't have their period. They have one period after they stopped the pill. They stopped having periods. Then they ran to me and like, Dr. Luke, I'm menopause. They really scared. Now, because as you know, Natalie, I do very, Dr. Crawford, I do diminished ovarian
Yeah.
reserve, and that's like my major, one of my love and my passion because I love those. I really love to tell the patient when they're AMH, they're in tears. I was like, don't worry. Do you have a partner? Yes. Do you want to get pregnant? Yes. Don't worry. Go and have sex. You're going to get twins or have a baby. AMH is no. It doesn't mean that you cannot get pregnant. So that's more of my passion. But any case, they ran to me. They don't have the period after they stopped the pill. And I would be like, oh my God, don't worry. I saw your ovaries have many follicles. So what happens to some of this patient is that either they lost so much weight or something happened with the energy balance. And
Hmm.
during the years, and that also takes time to dig because we ask patients to work out. Oh yes, we do. But then if you don't dig, means asking exactly how they work out. I mean, I'm in New York City. I have patient ran 5 miles. Think is, I don't know. I get huffing, puffing, and dizzy and collapse after 1 mile. But they're like, oh, now I feel very uneasy if I don't do 10 this weekend. I was like, oh, okay. I'll 10. So it's like then the energy balance sometimes happen and then they stop having their period. And then for them it's very easy. I would either give them Clomid or letrozole to get them stimulated and have the pills, but I mean have the ovulation with the risk of twins, obviously, because now you're stimulating the ovaries. Sometimes they gain back the weight or to get the energy balance. But this is fascinating to me. And this, it seems like I see a little bit more. I see about 3 to 4 women per year with that kind of diet, like it's not like something wrong with them. It's just they don't.
Yeah, I actually see that a lot too. And, part of it might be that I'm also in Austin, so it's quite healthy here. And, we have a university, so a lot of college athletes. But I think one thing that people don't understand, to your point, is that when you've had that disruption in energy balance and your brain has decided, it's not going to support you being pregnant at this exact moment, it can take years for the brain to be convinced that things are normal again. And so even though maybe you gained that weight back 6 months ago, you stopped the pill now, that's what I think confuses people so often, is that they've fixed the problem, but their ovulatory cycle is not quite back yet. And so I
Mm.
often say the same thing. It can take quite a while for the brain to be convinced to kind of get those signals back for ovulation. That doesn't mean you're running out of eggs, and ovulation induction or other options can be excellent to try to fast track that process. But I think it just really speaks to really encouraging, healthy behaviors, the source of, taking in enough calories, healthy activity. We certainly live in a time where, even though, yes, obesity is harmful and inflammatory when it comes to your fertility, so is being too thin. And I think that we're
Mm.
living in a time, I mean, at least here in Austin, and I would fathom in New York too, where people really are trying to be thin. I have a lot of patients on, medications to be even thinner who already have, a very
Wow.
normal BMI. So I think it's important to know that, weight and energy on both ends of the spectrum can be harmful to your fertility.
No, thank you.
That's a great
I
point.
had Thank you. I then here, this is interesting. These are all questions that's submitted by our audience, Dr. Crawford. They ask really intelligent questions. Can ovarian cysts cause infertility? This is a deep question. Dr. Crawford, want to take
Oh,
it?
yeah. It
I will do it.
depends, right? So it's going to depend on what the cyst is and what causes it. And this is really a big question for a lot of things that we try to make yes, no questions in the fertility world. So there's definitely benign cysts. You have a cyst every single month when you grow an egg to ovulate. And after you ovulate, you have a corpus luteum. And those are essential parts of getting pregnant that are ovarian cysts. However, another type of ovarian cyst, like an endometrioma, is known to be associated with inflammation, decreased ability to get, decreased fertility rates, decreased egg count. So I think it's going to depend on both ends about what type of cyst it is and what the game plan is. Often, even if it looks like a benign cyst, if this is somebody who potentially might need IVF for another reason, then it makes sense to sometimes, not always remove the cyst first, because that might, impact your egg count or other factors. So I think when it comes to cysts, it's not quite as easy and straightforward as a yes, no. It really depends on trying to get to the bottom of what it is. And I think my big, FYI, and probably yours too, is that cysts in the ovary are normal part of the ovulation process. So they're not always a negative thing. But if you do have a cyst that potentially needs to be operated on or could be problematic, it's always a good plan to have the entire fertility workup completed so you really know what you're dealing with, so that you can make a game plan moving forward.
I want to explain ovarian cysts also in a little bit more simplistic terms. I see a follicle is a black circle, and some of you who look at ultrasound, you will see that on ultrasound, and the doctor say, "Oh, look, you have a 90 millimeter follicle." So the follicle, depending on when it appears in your cycle, we give it a different term. So if that follicle, that's the same black circle I see at the beginning when you have a period, we call them a simple cyst. So I know patients like, I don't want cysts, I only want eggs. I'm like, wait, you need to have follicles, which is in the middle of the cycle, and then they need to be stimulated. They do look like cysts, but actually they have follicles because they appear at the right time, which is the middle of the cycle, and we get them, and then they will be eggs. And then after retrieval, patients also say, I don't want those cysts. I only want eggs. I'm like, wait, you have 20 follicles, which I retrieved 19 eggs yesterday. And that patient with lots of what we call hemorrhagic cyst at the end of the cycle, or just for audience to know, is lovely to have cysts. That means your ovary is still functional. As some of you may know, again, we experience and love diminished ovarian reserve. So we see lots of perimenopausal patients also, and their ovaries are very quiet. So having cysts and follicles is a sign that your ovary is still functional. So yay. We just want them to appear at the right time in the menstrual cycle, so then they don't interfere the production of the follicles. Then one more point to add, and Dr. Crawford, with lots of questions coming, so hopefully we can cover everyone. Is on our right side of the board. I just say thank you for your questions, so we have to attend to them. One more thing is endometrioma, which is a complex cyst that Dr. Crawford was alluded to. So complex cyst or endometrioma, a disease for something called endometriosis. Oh, my friend, I always get my friend here. I forgot the name. There are lots of suggestions of the name, so this my ears. But there's a big cyst on the ovary, and then when the cyst is there, they sometimes can cause inhibition of forming good follicles. Now, this is the catch, guys. So many patients, well, remove it then. So when you remove the cyst, some, surgeons can do the best they can, but it does affect collateral blood supply. It can affect the follicular healthiness of the ovary. So whoever is the surgeon, as long as they're a great surgeon, then we have to be as careful as we can not to affect the healthy ovarian tissue. So removal is not all benefits. There can be risk. Then usually for some of our patients who, especially for egg freezing and have endometriosis or inflammation, we say, go and get your eggs first because it is not in our way. Let's retrieve the eggs and we'll observe this complex cyst as long as we go, if it doesn't bother you. Because majority of the patients who come to us for egg freezing, they also do not feel the cyst. They came in for egg freezing and I identified the cyst. They're like, what? I have a cyst? And I'll be like, yes, but we can observe it. Likely you have it for the last 10 years. So they usually observe the cyst and then that's that. When the cyst need to remove is usually when it is symptomatic. And when there's a size, I would love to hear from Dr. Korf what size, but here we talk about 4 to 5 centimeter. When it's growing bigger and causes pain, I know some journal articles talk about 5 centimeter, but those are the different guidelines.
Similarly here, usually 4 to 5 centimeters, but often the timing of that removal, I completely agree. If we think we're in a position where we're doing IVF, if we think we can get to the eggs and leave the cyst in place, never want to risk disrupting the blood supply or, harming the other ovarian tissue when we still need those eggs. So very often try to get the eggs first and then observe and see what happens to the cyst. But of course, I think one thing to notice or to mention, the reason why that 4 to 5 centimeter recommendation exists is not because the cyst is more likely to be harmful, but it is for the risk of ovarian torsion, which is when your ovary can twist on itself and that can cut off the blood supply. And that could be it's one of the few surgical emergencies that we have, and it could result in you potentially losing the ovary. So if you do find out you have a large cyst and your doctor, you see Dr. Luke, and she says, hey, we're going to do IVF first, but don't go running. I need you to not do this type of activity. You should absolutely listen to her because she is trying to decrease the chance that that ovary bounces around in your body and twists on itself. And the analogy that I always use for patients when they say, what can I do? What can I not? Is if you imagine your ovary is a water balloon down in your pelvis, I need it to stay there. So if it's something that would make that balloon move, it's a no. If that balloon is just going to sit there happily, all good.
Fantastic. Thank you, Dr. Crawford. Destiny, do you want, because some of them are pretty, thank you. We have a question. Love the board.
I have HPV and have not had any testing done. Does that affect fertility in general?
Dr. Crawford, you go first and I can come and wherever.
Yeah, in general, no. However, certainly HPV can be inflammatory and can be a risk for cervical cancer, and that obviously could significantly impact your fertility. So as long as just having HPV, presuming that you've, had the recommendations by your OBGYN, had your colposcopy, or they followed PAPs to make sure that it isn't something harmful, then that's not something that, is generally thought to truly impact your fertility. So as long as it's something that you're following those recommendations, that's not something that I tend to worry about.
Nothing to add. Great.
Fantastic.
It's a
Next
simple.
question.
Next
I just
question.
got diagnosed with PCOS at 19. What should my first steps be?
So I'm gonna take it here first, and then Dr. Crawford, please help me out. But basically, for my patients, I'm really concerned about how regular their period is. I know in terms of how regular it is, there's some guidelines about having 4 periods in a year. That's why there's something called seasonal. Not having period for a long period of time is one of the worries that we have. Something called hyperplasia is rare. Endometrial cancer is very rare. It's 1 out of like 10,000, 1 out of 1 to 4 out of 100,000. But it is not that it can increase the risk because of the PCOS or because of endometrial hyperplasia, as long as if you don't have period for a long time. So those are the things that I caution most. PCOS is also associated with our healthy and diet, which Dr. Crawford actually we were just talking about right before we come on about how diet and want to talk about how it affect fertility. So PCOS does associate with diabetes, overweight for certain patients. Also, PCOS is also complicated. So let's define what's PCOS before I keep on going in. One, you have irregular cycle, and ovulatory cycle means you don't cycle once a month, or you have a long cycle like once every 3 months, once every 4 months. Second, you have a physical or a chemical evidence of high testosterone. What does that mean? Yes. So hirsutism on the lips, losing hair, acne. So these are just a couple of few physical symptoms. Or chemical symptoms. You have no signs of this, but then when you come to me, I check your testosterone level is very high in your bloodstream, or something called DHEA. So those are all values that correspond to high PCOS. Then so 2 of the 3. So the third one is having a high antral follicle count on both ovaries. What does that mean? It's about 12 less than 10 millimeter follicles on either side, 10 or more. Less than 12 or more, less than 10 millimeter follicles mean lots of little cysts. And then patients say, Dr. Luke, my OB/GYN, when 10 years ago told me I have lots of cysts on my ovary. Yes, that also called cysts. But basically, there are little follicles that are 7 to 8 millimeter in size, little circles on the ovaries. And so you need 2 out of the 3 criteria to fulfill, called the Rotterdam diagnosis. And Dr. Luke is not going to present you all the other criteria. That's also other agency and societies that also present PCOS criteria. But these are the 2 out of the 3 main criteria. And so if you're a 19-year-old and some doctors say you're a PCOS, likely you went to him or her because you have irregular cycles. So something that makes you symptomatic, or acne, whatever, then you read something, you went there. But most of the time it's irregular cycles that drive a patient's go to say a doctor, and majority of the time they tell you have PCOS. And I want to be cautious about PCOS since we're at this topic. I always tell patients it's a syndrome. It's like COVID. You don't have to have smell loss, fever, or coughing to have COVID. You can just have nothing. You can have COVID because the test right COVID, or you have just a smell loss, but you feel great and you can have COVID. So it's a syndrome. So I have seen patients who only have one characteristics or 1.5, like they don't really have loss of hair, they don't really have normal testosterone, but they have irregular cycles. But I can see they have PCOS because I see their ovaries. So they don't have to fulfill all criteria. So PCOS is some of the dynamic, and lots of patients get very lost. I may or may not. They say I have this, but not this. But you may, because you're in the gray area of having some syndrome or some part of it, but not 100% of it. And we are all, as we conference today mentioned many times, we don't believe in one. We don't belong in one category. That makes medicine so fascinating, and I'm so passionate about it and so interesting. We're always believing the gray. Are we darker gray? Are we lighter gray? So that's how I see medicine, and all my patients also. They don't believe in one category. And so at 19, I will really want to focus on that you even come to the conference, kudos to you, yay, that you're learning about PCOS, that you want to take part and be empowered. But one of the most important thing, if you're not seeking for pregnancy, is have regular cycles, and all the symptoms that I just mentioned that may be bothering you. You may want to seek a doctor to talk about it. And I think in terms of fertility, and this is my last point, I'm going to give it to Dr. Crawford. Actually, lots of PCOS patients does not need to see me. Haha. They have ovulate irregularly. They have sex in the 20s. They can get pregnant. PCOS, as long as you ovulate, maybe irregularly. I know you're like, irregular. How do I have, but people have sex. Sperm survive 72 hours in the cervix. So if you have regular sex and you have PCOS with your regular cycle, you can still get pregnant. You don't really need a fertility doctor. Dr. Crawford, take it away.
I think all of that, I co-sign everything you said, but I also think it's important for people to know there's so much chatter about PCOS on social media sites that can really lead to a lot of confusion. The idea that you can cure your PCOS is really a fallacy for the biggest degree, meaning just nobody's really out here talking about curing your thyroid disease, right? Like there's no shame or stigma in taking your thyroid medication, but PCOS does carry a lot of stigma with it. And there's a lot of people promoting, oh, you follow my plan and it'll magically cure your PCOS. And I always say the root of the problem is truly an ovarian dysfunction and how your ovary is responding and your brain ovary communication. And sometimes you should absolutely do what you can to try to make it as good as possible. And what I mean by that is a lot of the things that happen in PCOS with increased testosterone and insulin resistance and weight gain are all very inflammatory, and that causes noise to the brain. So it confuses the brain even more. So when we say, well, what can I do from a lifestyle standpoint? It's all about trying to decrease some of that inflammation down and be very aware of your body. But there's no harm in taking birth control pills if that is the recommendation, or being on spironolactone to lower your testosterone, and making sure that you take progesterone if that's the recommendation to have periods. So I think what you do at 19 really does depend on your goals at the moment. I saw this patient, well, not this one, but a patient just like this today, who, is just wanting to start to get pregnant, soon, and essentially saw on social media that birth control pills caused her PCOS and was just harboring all this guilt about it. So I just wanted to kind of add that, free yourself from the notion that you did anything to cause it, or that there's, one particular thing that you can do that can cure it, and view it like a syndrome. Everybody's going to present a little bit differently. Understanding what it is so that you can control the variables you can is really important. And I love that. If your periods are irregular, you're still ovulating sometimes. Yes, it can be very frustrating and hard to capture it, but if you're having regular sex, especially if you're young, fantastic. Sometimes I see patients not having sex because they're saving it up for ovulation, and you should never have less sex if you're trying to get pregnant. So that's one thing that can be really, really frustrating. But on the same end, if you know you have PCOS and you're waiting longer, that definitely might be a situation where you do come see one of us a little bit sooner so that we can make sure that PCOS is not the only thing going on.
Thank you, Dr. Crawford. Destiny, I know.
Fantastic. I know we have another question. We are getting so many great questions. So what does fertility look like for me with endo, uterus polyp, low AMH at the age of 28? What's the best approach? Natural, IUI, IVF? What are we going to suggest?
Great. I'm going to take it away, and then Dr. Crawford. Okay, we have limited time now, so so here we're going to go, because this is lots of topic here. Endometriosis, uterine polyp. So, first of all, at the beginning we talk about we need 4 things to get pregnant: tube, uterus, egg, and sperm. So low AMH does not define that you cannot get pregnant. Like I said, please go and have sex. If you do have a partner, the approach is you have low AMH, go and have your first baby, your second baby at 32, and hopefully your family complete. But you say, no, I want third baby, do it at 34. Low AMH does not define fertility potential. So please go ahead and try. Endometriosis. it's all about age. I know it sounds really bad, and hopefully I'm not making any audience unhappy because they're older, but age plays a huge factor in fertility. So as long as you're young, and that's why I was talking about PCOS, endometriosis. I have endometriosis. I didn't have any issue at my young age of 20s. I had issue at 35, 36. So either, yes, you say, doctor, maybe your endometriosis got worse. Maybe. But I also think it's because I was 6 years older. And so age play a huge factor in that. So even you have endo, one advice will be make sure your tube is great and is patent. Sperm is good. Uterine polyp depend on the size. So in my young years, we did lots of at Brigham. We did polyp size. I know in residency we look at 1 centimeter versus 2 centimeter polyp to inhibit implantation. So one of the big paper came out in the 1990s and in 2000 was a 2 centimeter polyp paper saying anything over 2 centimeter you should remove. And the then my paper came out with 1 to 2 centimeter polyp that we discovered that have a lower implantation. But things that's under polyp, I've seen lots of patients. It's fascinating. They have their first baby, and they think they said I had that polyp and I got pregnant, and now I'm having trouble get pregnant 3 years later, and I saw a polyp. But because we are all fertility doctor and REI doctors, we love a normal uterus with smoothed walls. So I did recommend patient to remove the polyp, but really polyp size really depends on the size, location. Depends if you need a surgery to remove it. Dr. Crawford.
I agree totally. And my favorite question when something like this is, well, what is our goal, right? Because if we do have a low AMH at 28, to your point, yes, I would take out the polyp because we do love things to be perfect. But, getting pregnant naturally, as long as the other factors are all normal as well, can be a wonderful option. But I always want patients who have a low ovarian reserve to, make sure that your partner's getting a semen analysis, make sure your fallopian tubes are open and that you don't feel like you're wasting your time if, for example, your partner has no sperm. That's going to be extremely frustrating to not find that out for a longer amount of time. But this might be a case where we accelerate an evaluation, depending on the size of the family you want. We might talk about different options because it's not that the low egg count could potentially impact you getting pregnant now, but it's about the entire picture. So I think it's a really great question. It's going to be a personalized approach, I think, for all patients, really having a good rapport with your doctor. Go see Dr. Luke and, tell her what your goals are so you guys can make that game plan.
Dr. Crawford, you're right. Time flies. I didn't. I don't think I'm like worried what I'm going to talk with Dr. Crawford, but now it is like already our sessions is nearly over. But I want to really thank you. It is amazing talking to you. It's always been my dream, and thank you for being here today. I hope this helps our audience, patients, and thank you, Dr. Crawford.
Thank you so much for having me. And I'm honored to be here. I love everything you're doing and for having this entire event just to help people. Absolutely love. So thank you so much.
Thank you so much, Dr. Crawford. I know you have to hop off, so I'm going to do a little closing with our team and then we go on. Okay, see you, Dr. Crawford.
Bye.
Bye-bye.
Dr. Crawford, thanks so much for joining us.
Wow, what a day, Destiny.
What a day. I mean, can you believe it? We did it. We're here.
Now, I'm so happy. I hope the audience enjoy their time with us the day today. And I just want to tell you that the reality is let's be honest, there's so many unknowns in the world of fertility. And I hope this conference and what we did today really help with the audience. We'll hopefully get some feedback. I bet our audience are very empowered. They always have great suggestions. Yes, more meditation, less meditation. So I'm looking forward because I know, Destiny, you're thinking about doing this again we are thinking about doing 6 months. Springtime, we'll be having another spring summit.
We're going to have to. We have so many questions and we're going to have to do part 2 and part 3 with all this audience engagement.
And I want to tell the audience this part about my closing, which is there's so much fear and uncertainty of infertility, which are heavy burdens to us. And there are many things we cannot control. But hopefully through these conferences, we able to communicate, to express. Like I even see some of the great questions that people are asking, what causes the anxiety, causes the fear, and how we can answer to it. And so I really thank you for the audience to join us today. This is amazing.
Yes, it's amazing, amazing, amazing.
And I also want to thank you. I know there are lots of background people here. Issy, Harvey, Sydney, you, Destiny, and leading this team. And thank you, guys. I still remember Izzy today was like, Dr. Lu, do you need to comb straight? I'm like, oh, thank you for my hair. Because, some of my patients, oh, Dr. Luke, I wear scrubs today. I'm nice. And thank you so much, Sydney, Issy, and Harvey. You guys have been amazing for getting this all together, for all the reminders, because Dr. Luke sometimes run on the Dr. Luke's hour, but now today I was here with all of you. So thank you for making this happen. So Destiny, I know we have our next, this wraps up our Fertility Wellness Summit on internet, on
Yes,
Tally.
that's
And
right.
you now take it away. We are having our second part here in New York City,
That's right.
Lowe's, for our panel. Take it away,
Well, it's going to
Destiny.
be great. And this wraps up our first ever Fertility and Wellness Summit. I can't believe it. It was such a great day. Thank you again to Dr. Crawford, Dr. Luke, all of our esteemed speakers for sharing their expertise today. Be sure to check out our on demand sessions, social media for videos. We will be streaming our next session, which will be in person at the Lowe's Regency live at gen.next.fertility. So definitely feel free to check it out. And we're going to have Dr. Luke, Dr. Naja, and Dr. Haid from Generation X Fertility, and Dr. Angela Lee and Dr. Megan Lynch from Fifth Avenue Fertility Wellness, when we'll be speaking about diminished ovarian reserve.
My
So
passion,
I
my
know it is.
topic. We chose it to close that, which is I have less eggs. Can I have a baby? The answer is yes.
Yes, you
Yes, we
can.
can. So I can't wait to see you guys there. I'm
I
going to
can't wait.
see you then. I'm to run over. So
Okay, well, let's run over. Thank you so much to our
thank you,
educated,
the
empowered,
audience,
and
for
excellent
joining us.
audience.
Bye bye,
All right,
guys.
we'll see you then. Bye.